My name is Mitt Joyner, and it is a pleasure to be here on the Essential Chats with Mitt. And I am surrounded and going to be surrounded by a group of individuals that we will bring on as we move along. But first, I want to tell you, we always start off with what's the song of the day. And this one is going to be I Will Survive. At first, I was afraid. I was petrified. Kept thinking I could never live without you by my side. But I spent so many nights thinking how you did me wrong, and I grew strong, and I learned how to get along. And so far, we're back. And it goes on and on. Well, I kind of want to tell you my story about when I was petrified. It was back in 1995. And my daughters were graduating from high school. My twin daughters were graduating from high school. And I was actually teaching at Westchester University. And it was in the early spring that I went for my obligatory mammogram. And then the next thing I know, because I had lumpy breasts, I always had to go through a series of things. I had to then go back and this time they decided, or the radiologist decided, you know what, we should do a biopsy. So they did a biopsy. And I remember my OBGYN waking me up and saying, you're going to be all right, but you have breast cancer. And I was petrified. Breast cancer? Are you kidding me? Because anytime anyone hears the word cancer, you literally think you're going to be gone. And I had daughters, twin daughters, and another daughter a few years later, who was going to take care of them, who was going to help them with the prom, who was going to do all of these things. I didn't know what to do. I had breast cancer. How did that happen? Because to be quite honest, my weight was the best it ever had been. I had exercised. I had done everything. And I was the healthiest and the happiest that I thought I could be because my twin daughters were graduating and they were going to be leaving the house. They did what they needed to do. And I was just going to have a different type of life. Well, there were other plans for me. The next thing I know, I had to pick a doctor. And so, I went and my OBGYN referred one doctor to me and I went and I met her. And quite honestly, I really didn't have that feeling of this was going to be a person that was going to help me save my life. I kind of had the feeling that she's okay, but she gave me a book. And of course, when someone gives you a book, what do? You read on a how-to book, you read the last chapter first. And that's not what you want to do when you're going through trying to battle breast cancer. So I talked with one of my girlfriends who was diagnosed with breast cancer several years and was a survivor. And she told me about this doctor in Bryn Mawr. And, I was a woman, so I really wanted to have a woman doctor, but this was a man. But I said, okay, I'll go. Because nothing's wrong with getting a second opinion. And we'll talk about that as we go further into the show. So I went to this doctor in Bryn Mawr. And when I called, he said, bring your husband or bring your spouse or your partner, bring somebody with you, which was the first time that I knew that I was going to kind of like this doctor because he was not going to have me. I didn't have to remember everything because all of a sudden the terminology and the language that's being used is above my pay grade. I just didn't study medicine. So I went off to see Dr. Frazier. And the one thing that I can say is when I went to see Dr. Frazier, he did not sit behind a desk. He pulled his chair right up beside me. And he started talking to me and my husband. And he told me exactly what they need to do and that I was going to need to have a team of people around me. That if I decided to have a mastectomy, I would need to have a plastic surgeon. And if I also was going to need to have an oncologist. So he recommended people, told me to go talk with them, be comfortable. If not, we'll go back to the drawing board. He actually drew my breast and kind of showed me the area that was of concern, talked about what it would mean. And I just said to him, Dr. Frazier, I'm too busy to have breast cancer. I don't have time for this. My daughters are graduating. Don't you understand? I need to be there at their graduation. Also was just elected as far as to a national office. I need to be going places. How is this going to impact me? And he said, we're going to work on this together. And if you just trust me and we trust this team, we'll get you through this. I don't know what all is going to happen, but we'll get you through this. And that's what I did. I mean, kind of why I understand these anti-vaxxers that are around here saying, I don't want to get vaccinated because I don't know what's going to happen. Because when you don't know what's going to happen to you, the easiest thing is to take in misinformation. My friends, some were calling me thinking they're giving me good information. Don't do chemo. That's rat poison going inside you. Don't have a mastectomy. All these decisions, everybody had an opinion. And I had no idea what I needed to do. But I did know that I needed to survive. And even though I was petrified, I was going to do this and scale this elephant down, as Dr. Frazier said, so that it becomes manageable and something for me to navigate. This occurred in 1995, and now we're in 2012. 26 years ago, I was diagnosed with breast cancer. I did choose to have a mastectomy, so I did have to have, go and have another doctor who was there, and that breast doctor did every now when I go in to be examined, he did a great job. And I did have an oncologist, and my oncologist told me that every day I could wake up and I would say, oh my God, I got breast cancer. And 10 years from now, waking up for 10 years, you would have missed life. Or am I the kind of person that wakes up in the morning and says, oh my God, I had breast cancer and I'm going to live this day to the fullest. So in 10 years that I would have been productive. I chose the second path. And I decided that I was going to wake up every morning and say, oh my God, I had breast cancer, but you know what? I'm going to do everything I need to do today because I'm in here today. I'm living today. And that's what we want to talk about. So the first person I'm going to ask is a friend of mine that I happened to meet, had nothing to do with breast cancer, but it was Dr. Vivian Jolley B. Actually, one of my students in my class one day said, there's a great doctor I'm working for at MD Anderson at Cooper in Camden, New Jersey. And you need to meet her because you all have a lot in common. And so I thank one of my students, who is Dr. Leslie Putty, at that time, Tar, who is a social worker, actually made a connection. So remember your connections, people, because we're going to talk about this from the perspective of people that go through being diagnosed, as well as the perspective of you who help people who's going to be diagnosed. So we're going to turn this over to a gifted surgeon and board certified general surgeon who has experienced and was trained in breast surgical oncology. And now she is at the prestigious MD Anderson in Houston, Texas. And now she's in New York. But one thing that resonated with me about her, she has a passion. She's a hard worker, and she's dedicated to saving lives and improving the quality of life of all of her patients, and has made herself a rising star in the medical field. So I'm going to let Dr. Jolley talk to you a little bit, and then we'll move on. So Dr. Jolley, do you mind coming on screen, and we'll keep Jean and someone else that we have, Rosie, and we'll talk to them as we move along, and I'll tell you a little bit about them. But it's my pleasure and honor to have you on the show. When I asked you, you didn't hesitate. You just said, what's the date? So I can get it down on my book. So tell us about you.
I sure will. And let me just say, thank you so much for inviting me. I don't know if you know, but I am truly inspired by your strength and by your story. And I think that it's important for others to hear that strength and that story as they help navigate patients. And as patients help navigate themselves. And so, as you mentioned, I am a breast surgical oncologist. And really, my platform and mission has always been to serve all women and to provide quality care to any person who walks in the room. And I chose the path of breast surgery. Well, number one, I enjoyed surgery. I wanted to be a surgeon, but I also enjoyed women's health. And just a step further, I enjoyed the opportunity to really walk someone through, as I call it, a dark tunnel. And, because I do and have seen the light at the end of the tunnel, and helping them navigate that from the very first interaction. And Mitt, you said something that resonated with me, and that is when it's the doctor-patient relationship and how important that relationship is. And it's a relationship that I don't take for granted at all. And it's as important as when the patient comes in, sitting down, looking them in the eye, trying to understand where they are in life, meeting the patient where they are. And so what I will say, I think there are a couple of pointers that you mentioned. I absolutely support second opinions. And I think that that's something that we should, sort of highlight and suggest to patients, that you don't have to go to one person, and that's the person that who's going to be on this journey with you for a long time. Go see someone else and make sure that you are comfortable with that decision. And if you don't have comfort in that physician, go find another physician. You will find your match. I'm confident in that. And so there's also the question of, how do we find that physician that is going to sort of connect? Well, we all have different styles, and I will say I'm a people's person, and I know that. I know there's certain things that I can relate to with my patient population. I serve a very diverse patient population. But what I will say for breast cancer, the first step is really to ensure that when you are referring patients, or when a patient is trying to find a physician, that you seek one out that has the appropriate credentials. And I know that's easier, sort of said than done. And you may say, oh, of course. And what I mean by that is finding someone who is specialized in breast cancer management, not a generalist. We have enough specialists in breast surgery and medical oncology and even radiation oncology. The other important factor is finding a multidisciplinary team. We know that social workers are so important in connecting patients and helping navigate the barriers that may or may not exist. And that's easier done when, if the opportunity is appropriate, where you have physicians who work together and can really develop a treatment plan for that patient. There are also websites. The American Society of Breast Surgeons is one of the largest organizations that you can find out who is certified in breast surgical oncology, and they meet certain quality metrics. Now, that's just the sort of logistics. Once a patient gets through the door and meets their physicians and their treatment team, which of course consists of nurse navigation and genetic counselors and research people, they really have to have a feel. And I say, go off of feel. How did you feel? In understanding that you're in a dark tunnel, but did you feel like your team could help walk you through that tunnel? And so again, I agree with second opinions. Mitt, again, you are courageous, and I'm excited to be here and sort of lend my thoughts on breast cancer care in this country, and really how to help navigate, patients. So I will pass it back to you.
Okay. Thank you so much, Vivian. We'll definitely have you in our little round table. Remember, you're all going to be at my house. This is a round table discussion. And so the next person I'm going to introduce you to is Rosie Nagy. And Rosie, I just met Rosie. And this is going to tell you all, don't ever meet Mitt because she'll put you on her list. We were at an NASW affiliate meeting. The Brandywine chapter was meeting. And I happened to go because I'm a member of the Brandywine chapter in Pennsylvania of NASW. And I like to go and just sit down and meet all of the people. And here comes Rosie. And she's telling me about her work as a social worker. And that the very fact that she is an oncology social worker. And I was like, oh, Rosie, I have a show. What date? Put this date in your schedule. See if you can be on here, because I wanted you all social workers out here to know about Rosie, about what she does, and about how she helps people every day. She's in the hospital and she's working with those individuals who need her help. You know, our medical model has changed. A lot of people now have surgery and go home, and they need to know where to get help and how to get help and how someone and what is a drain and how do I empty this drain and all of these things. And when I do it wrong, who do I talk to? So I'm going to bring Rosie up, and Rosie, you can kind of tell us about yourself. And again, I want to thank you. She is a social worker, so don't anyone question that we're not in this field, and we need more people as dedicated as Rosie. So let's talk with Rosie.
Hi, everybody. Thank you so much for having me, Mid. My name's Rosie. I'm a social worker here in Philadelphia. I've had probably about 7 years of experience in oncology social work. Initially, I worked about 3 years inpatient, and I actually work outpatient currently for the past almost 4 years working outpatient located in a hospital setting. So as Dr. Jolley said, and as Mitt was talking about, working with different professions within the medical team is really important for our medical center. And every medical center is different with how they work with their social workers and the other professions. But for us, our breast cancer surgeons are very proactive and love to work with social work. So our philosophy is we actually try to get social work involved as soon as possible. So even as soon as a first consult, the surgeon might come in and talk to us and ask for us to go meet with somebody just to introduce ourselves, even if it's not really giving too much information. At least patients know who we are, what we look like, they have our phone numbers, and they're able to call us in the event that they need anything. So if it is that they don't know who to call for a situation, like if they need medical assistance or if they're just not sure how to cope, then we step in to offer the support as needed. I will say, you know, when people get diagnosed initially, it's really frightening. And like Mitt said, sometimes people are really busy. Cancer might not be the first priority going on in their lives. So we really try to work with people to try to make sure, you know, that they understand what's going on, that they have everything that they need, that we're addressing any barriers that might exist for them to come into care. Another thing that, you know, Dr. Jolley had said was, you know, second opinions, and, you know, I support them as well. And I really support people having as much information as they need for their medical care. I feel like education on what's going on in the process is really important. Bringing someone with you to your doctor's appointments so they can take notes if needed, bringing questions into the appointment if needed, and stopping your doctor if you need them to fully explain what's going on is really, really important. So, yeah.
Thank you so much, Rosie, for sharing that story. And you're going to get back on our show after we talk with Jean Sachs. Now, this is an interesting thing, and I think people will find this really, really interesting. So, you know, as a social worker, it was hard for me sometimes to separate my personal self and my professional self. I was trying to social work myself. Right. And once that I was, you know, had my surgery and I was on the road to recovery and, you know, knew that I was going to have chemotherapy and, you know, was going to be in this for the long haul. This was not something that just you have the surgery in your mind. You tend to think I have the surgery and then I'm done. Bye. See ya. Oh, no, 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 no. So it was everybody wanted to say, OK, so what are you going to do? You need to go to a group. Now, at that time, I wasn't the group person. I wasn't the person to kind of say, hi, my name is Mitt. I have breast cancer. How do you help me? But I knew I needed to do something because I knew that I was on a journey. I could look to the left and look to the right every time I go to the office, and I saw different people with having different look differently due to their health. Whether some were in having radiation, some were also involved in chemotherapy. I knew, what am I doing to give back? I just can't. We just, social workers just don't sit idly by. So someone told me to go to Paoli, where they had this group of people living beyond breast cancer. It was a small grassroots organization at that particular time. Marissa Weiss was running that, and Marissa said, Dr. Marissa Weiss, I have this organization and it's growing. And right now it's at the top of my house. And I need to get it out of my house and into an office. But I need to hire a CEO to run that program. And I have this woman that I want to talk to, but I need you to go to her job interview. Now, I was there as a volunteer but just talking with Marissa and things, she kind of knew that I could get to the bottom line very quickly. And she said, I have this person I want to have, but I don't know if they want to come to us. So could you come to the Wayne Hotel? I remember, to the Wayne Hotel, and have dinner and meet this superstar who's a social worker. We really want the social worker for living beyond breast cancer. And I did. And I met Jean Sachs. And Jean was at a point of her life, and bottom line was, Jean, can you come work for us? And she chose to do so. And in the end, I ended up being on Jean's board. I mean, she had me connected with Living Beyond Breast Cancer for a long period of time. But what I liked about this organization was it was about, just take that term, living beyond breast cancer, so that you were able to scale that elephant back. But when you needed something, the agency was there. It was able to be supportive. They have warm lines, and they actually grew. And I hope that you will visit their website, because they're all over and they help people all over. But this is what connections do. This is what social workers do. All these people I was connected to that is on this screen. But I want you to hear about the work of Jean Sachs, who graduated from Bryn Mawr College, but has been involved now. I'm 26 years out, so you're 25 years at LBBC. So, Jean?
Well, thank you, Mitt. It's so great to be here. It's so great to hear Mitt's story. And I owe so much to her. And I really am a social worker at heart. And sometimes I forget it. And then my staff reminds me just how LBBC has grown, and the things that we prioritize, I think, really do come from my social work background. So I have so many things to say. I mean, Mitt put together, not surprisingly, an amazing group of people. This is part of your team when you're diagnosed with breast cancer. You need an amazing doctor, which clearly Dr. Jolley is, and you need a really compassionate, smart social worker. And Rosie is that. And, there's others that you need. And then we always say, you also need Living Beyond Breast Cancer, because we're always here for you 24/7. Nobody's checking the clock or having to get insurance reimbursement. So I'm going to tell you a little bit about what we do, but I just want to start by saying, when Mitt said, she was diagnosed in 1995, it made me think how much has changed during that time in the breast cancer world. And I know Dr. Jolley can talk about this as well. But there has been so much progress. It's really a completely different experience. So first of all, we didn't know in 1995 that breast cancer was more than one disease. We just called it breast cancer, and everybody kind of got the same treatment. And we are light years away from what that idea. And now we know that breast cancer is many diseases, which means there'll be many cures. So that means some people's breast cancer is going to be far more treatable than others. And that is a really hard thing, because you want to be in that group where there's more treatment options. So, we need the science and the research to keep moving. There was also so little for the metastatic community. So for those whose cancer has moved beyond the breast and is in other vital organs, women did not live very long. And in fact, now there's been so much progress, and some people live with metastatic breast cancer for a really, really long time. So I've been really fortunate to sort of be in this space for so long and be part of and watch all the changes that have been made. And of course, we ultimately want a cure, and we want less toxic treatments, and we definitely want to be able to diagnose breast cancer earlier, that, we still need better ways to find breast cancer. So it's been really an amazing job. So I owe a lot to MIT. Thank you, MIT, for giving me this opportunity. So when Living Beyond Breast Cancer started, MIT is right. We were a small organization based right outside of Philadelphia. We were founded by Marisa Weiss, a radiation oncologist, and she always had a national vision. And, I'm going to date myself, but this is really before the internet or websites or email. We worked really differently then. But we always knew we wanted to move, be accessible to everybody. So what's exciting, fast forward 25 years, is we really are a national organization. We reach about 600,000 people a year. And our whole mission is to connect people impacted by breast cancer with trusted information and a community of support. So what does that mean? We believe when you're diagnosed with breast cancer, you're going to do a lot better if you really understand your disease, and it is complicated. So we want to help you really understand it, get the right diagnosis, get the right testing. There's so much testing now that will determine whether you need chemotherapy or not. Do you have a genetic predisposition? What about genomic testing, which is what is the makeup of your tumor, to really guide you to the right treatment? So some people just want to start treatment immediately, but we always say, whoa, slow down, figure it out. And as all the other speakers have said, get a second opinion, get a doctor you really trust, you really feel comfortable with. And now we know, depending on where you live, that's not always so easy. If you're in a big city like New York or Philadelphia, lots and lots of choice. But we work with a lot of women who live in rural communities, suburban communities, and have to drive really far for treatment. So one good thing that happened during the pandemic was telemedicine, and being able to consult with doctors all over the place. So find a way to get connected or connect with Living Beyond Breast Cancer, because our programs and services highlight top medical oncologists throughout the country. So I want to just say that so much of what we do really supports the social worker. Our programs can kind of help you offer things to your patients that can make a huge difference. So the first thing I want to talk about is we have a fund called the Living Beyond Breast Cancer Fund, which started as a small fund that we only gave out locally. But because of the pandemic, we realized this is not just a health crisis, this is an economic crisis. So we raised money. We now give small grants away to women in treatment for breast cancer anywhere in the United States. They can apply on their own. Last year, we gave away almost $300,000. We're on track to give away more this year. So please go to our website, find the LBBC fund. We open those applications the first of every month. We try to fund about 335 applicants a month. We also have a helpline. So it's answered completely by other women that have been diagnosed with breast cancer. It's truly peer-to-peer support, and it's a matching service. So you call, you talk to our amazing woman that manages that program, Kaneen. She finds out a little bit about your diagnosis. Maybe you want to talk to someone with a similar diagnosis or of the same age, or someone who has kids, and anyway, we match you together. So again, a really nice resource. We can learn so much from each other. And then we also have closed Facebook pages. So if you prefer not to talk on the phone, which I know many people don't talk on the phone anymore, you can just be added to one of our closed Facebook pages and chat privately with a whole community of thousands of people that understand what you're going through. We also do conferences. They used to be in person, but right now they're virtual. So we have one just for those living with metastatic, and then lots of other programs, Ask the Experts, webinars, where we're just bringing you the latest information, answering your questions. And we also do trainings for healthcare providers. And this is primarily oncology social workers, nurse navigators, and oncology nurses, where we see really the frontline people and the professionals that really connect most deeply with the patient. So we help them better understand, what is it like for a premenopausal woman when she's diagnosed with breast cancer? And how does that differ from someone who's postmenopausal? There's so many differences. How can you best support them? The list goes on. And all of this, of course, is on our website, which is lbbc.org. So I'm really just honored to be part of this panel and looking forward to answering questions and being in MIT's living room, I guess.
Thank you so much, Jean. Thank you, Dr. Jolley, and thank you, Rosie, for being a part of this group. I'm going to ask Carissa Proctor to come on. Carissa Proctor is an intern who works with me at NASW, and she is another added voice, a young voice. And so when we were talking about this show, I said to Carissa, you know what, I'd like you to go out and do your own little focus group and find out what college students are thinking about. What do they know about breast cancer? What questions do they have? We're also going to ask all of you out there in our listening audience to write your questions, and we'll post them as well, because we want this to be interactive. So even though you see different living room backgrounds, we're all sitting at a table right now, and we want to answer your questions. And no question is too small or large. And so one that Carissa asked me was about, let's just do men get breast cancer? So let's just start off with that. And then Carissa, I'm going to turn it over to you to ask a few more questions. So do men get breast cancer, Dr. Jolley? So now I guess we all have to come off.
Okay, here we go.
Yeah.
Sorry.
Okay.
Yeah, absolutely. So men get breast cancer, and I think that's actually a great question, because we have lots of men who can really serve a role in breast cancer awareness. One, for themselves, we know that 1% of men in the United States will be diagnosed with breast cancer. And so it is important that they are empowered to know that if they feel anything in their breast, they certainly should go and seek attention and not just sort of push it to the side as being, whatever they think it may be. So that's the first thing. But we also know that men play a pivotal role in encouraging the women in their lives to go get screening and to follow through with, the breast cancer treatment that women would need. Now, as far as treatment for men, I think we don't talk about it enough. And so there's like this fear. If you don't talk about it, then you really don't know what to expect. And so the treatment for men is actually quite similar to the treatment for women who are diagnosed with breast cancer. Often involves surgery. Sometimes it involves a systemic therapy of some sort, whether it's chemotherapy or even a pill, and occasionally radiation. Most men will actually elect for a mastectomy, although that's certainly changing. So yeah, education needs to sort of be pushed forward for men. And while we're in your living room this month, as you know, I have done a number of talks across the country, of course, virtually, radio stations and podcasts, and also hosted events for a few of the major cancer societies. And I've learned actually a great deal. And I think, as sort of a pivot question, I hope you don't mind this, but breast cancer in the COVID-19 era, and really what that means. We actually hosted a 3-day symposium for primary care physicians and had all representation of actually physicians, cancer specialists, nurse practitioners, nurse navigators, social workers, and counselors to really discuss where we are now and what that means for a patient, from screening to diagnosis and having the resources available, to treatment, and is there a treatment delay because of COVID issues, and even now that we have a vaccine, having the staff and support. Hospital systems are stressed. And so I just wanted to sort of bounce a question to our wonderful Living Beyond Breast Cancer CEO and understand how patients are dealing with, having a diagnosis during this time, and what can we do to help sort of support them?
Yeah, I'm happy to talk about that. And thank you. I'll just start though, just to follow up on the question about men, because we have at Living Beyond Breast Cancer created specific resources for men. But keep in mind the statistics. So about 3,000 men are diagnosed with breast cancer a year compared to, I think it's around 149,000 women. I'm not sure if that's the exact right. So it is a really big difference, but it doesn't mean it doesn't matter. But there's often a lot of shame connected with that. So we have tried hard to sort of elevate some of those stories to reduce the isolation. And the other thing about men that you have to remember, because, we've learned a lot about genetics and hereditary breast cancer. So remember, we get half our DNA from our mom and half our DNA from our dad. So that BRCA1 or BRCA2 or other mutations that we're learning about can come from either parent. I think there's always this sense, it has to come from my mom. And that's actually not true. And that's why some families don't often realize, they don't look at their father's side of the family. And if men carry that those genetic mutations, they are at higher risk for prostate cancer, colon cancer, other cancers. So that conversation is so important. And thank you for bringing that up. I think, and then there's a question about special concerns for trans men. And all I really have to add is that if anyone is taking a lot of hormones, they need to think of themselves as putting themselves at higher risk for breast cancer. And Dr. Jolley can probably add to that. But I think we don't really know what's going to happen with this, but it's something to pay attention to and definitely be talking to your doctor about. To just quickly talk about COVID, wow, it's been tough for anyone diagnosed with any disease during COVID. When we were supposed to be staying at home, you couldn't stay at home when you're supposed to be isolating. Keeping everybody in your family safe if you're immunocompromised. So I think there were a lot of challenges not having anyone be able to go to chemotherapy with you. This is where our amazing social workers and oncology nurses really made a difference, because they were often sitting with the patients because friends and family couldn't join. So having surgery and not being able to have anyone in the hospital, and of course, worrying about your exposure. And then certainly delayed diagnosis. We're just starting to see this. I'm sure, Dr. Jolley, you're seeing this in your hospital. Long waits to get mammograms now. Lots of later stage diagnoses. We put a lot of focus on protecting ourselves from COVID, and we stopped doing those things that we still have to do every year. So I think that we're not out of this yet, but we always say, don't stop your regular health screenings. It's really important.
Rosie, do you have something to add to that?
Yeah, I would say in addition to kind of the concerns with delayed care and the general changes that we've seen in the hospital setting, I think it's also important to note that for a lot of the women that we've been seeing, they're also parents. And so with schools not being open and a lot of kids being home, it's been really difficult for a lot of our patients who are parents to manage the parenting role as well as treatment. It's been a lot of increased anxiety and just increased unsureness of what's going to happen. It adds that extra layer of distress that we've been seeing. And so I know for us, we've been taking extra care to check in with people just to see how things are going and seeing if there is anything that we can do to try and help lessen that. But I think it's really important to note that, the other parts of life have been impacted as well in COVID-19. And that's definitely been adding just significant amounts of stress to people.
Okay. Carissa, I'll let you go.
All right. So I guess I'll start off by just sharing the results of the focus group that I did do. So the first question was, do you self-examine for breast cancer? And 45% said yes, and 55% said no. And then I asked, did you know that men can get breast cancer? 45% said yes, 10% said no, and then 45% said they never thought about it at all. Do you have any insight into why the results might look that way?
I mean, not surprising to me. I'm sure Dr. Jolley can talk about this. I think people really don't think about men and breast cancer because we think of breasts as something only women have. I mean, we all have tissue around our chest. That's what it is, right? So that doesn't really surprise me. But I think the issue about breast self-exam, and I'd love Dr. Jolley to talk about this. I think there's a lot of confusion, and there's been a lot of confusion out there. Like, should you do it? When should you do it? You know, clinical breast exams, are they in, are they out? And I think people might be confused, and people may not feel like they don't know how to do it. Remember, about a third of breast cancers are found on mammograms, about a third are found on clinical exams, and about a third are found by the woman herself. So kind of need to be doing all of them. And how old you have to be when you start mammograms is also another controversial issue, but I'm going to let Dr. Jolley, who's more of an expert, talk about it.
I'm so glad you threw that one back at me because I am passionate about talking about screening. So, Carissa, to answer your question, am I surprised? I'm not surprised, and I'm also not discouraged. I think focus groups are an opportunity to understand where we can do better in educating. And as I give my community talks, one of the things that I have noticed is that no, we don't have college students who are present in those focus groups because we're focusing on women who may have just turned 40 or in their 30s or older who are now going to get screened. And so, what we try to tell them is the information that we pass along to you, it's important for you to pass along to your daughters and to the younger generation. And so a segue is to talk about the breast screening recommendations. And this is what I will say. There are different opinions on screening and even doing self-breast exams. And I will tell you that most breast specialists, and particularly breast specialists who understand that we are still in need of addressing the disparity in breast cancer, and I'll explain some of the disparities in breast cancer. That there are certain recommendations that we should not follow, and there are certain recommendations that we should. So let me explain the disparity. We know that in breast cancer care, that when you even look at race and ethnicity, Black women, while they're slightly less likely to be diagnosed with breast cancer, have a 40% mortality compared to white women. And so some of the recommendations are that screening should start at the age of 45, 50. Well, guess what? We also know that Black women are more likely to be diagnosed before the age of 40. So, in fact, pushing the screening recommendation to an older age doesn't make sense when we haven't won the war on disparities. And so most breast specialists like myself recommend that for an average risk woman, and this is based on the Society of Breast Imagers and American College of Radiology, NCCN guidelines, as well as the American Society of Breast Surgeons, that for average age women, you start your mammogram at the age of 40 and continue every year. Now, you may have primary care doctors who say, start at 45 and do it every other year, but that is not what breast specialist societies are recommending. And there's also, to address the disparity, how do you know if you're average risk or you're high risk? So now the Society of Breast Imagers are recommending that at the age of 30, every woman have a risk assessment, which really looks at their whole medical history, not just family history, which is important, but their medical history to determine if they need to start screening even before the age of 40. And so I say all of that to say education is important, and I'm so interested in hearing what the younger generation is saying, because it gives us opportunity to address those areas of missing information.
I want to just add to that, and so well said. And it's horrible that we've confused people, right? Like, that's not what we want to do. We want to be able to give clear messages. Living Beyond Breast Cancer started a program last year called Knowledge is Power, Understanding the Black Breast Cancer Experience. And it's a 3-part series. Actually, it kicks off next Thursday, October 28th. I can link it in the chat. But the whole reason we're doing this is what Dr. Jolley talked about. There are true disparities, especially with Black women in the higher mortality rate, but also just how they're treated, the access to care. And also the statistic that's just always striking to me is there are only like around 200 and change Black medical oncologists in the country, and I think fewer Black surgeons, breast surgeons. I think you may know that as well. So the likelihood that a Black woman is going to see a doctor that looks like her and can relate to is pretty small. So what we've really been trying to do through our programming is highlight not just Black doctors, but all different ethnicities. So at least they can come to Living Beyond Breast Cancer, get their questions answered, and know that these healthcare professionals are there. We just need to catch up. So thank you for bringing up the disparities issue.
And so first of all, let me just say, I love that you have a particular program that really focuses on it. And you mentioned the fact that, yes, you know, when we see representation matters. I mean, I think that's what it all boils down to. Representation matters. And we know based on studies that patients who can relate to their specialist, you know, they're able to be more accepting of the recommendations that are being offered. They're more comfortable, and their journey through a breast cancer diagnosis is better. But you're right. You know, we have to address the fact that it's not easily available to all patients. And so again, going back to you, Carissa, this is why your voice matters, and really sort of, you know, pushing forward and helping us reach down to the younger generation, that pipeline programs are important, that we have social workers who are representative, nurse navigators, nurse practitioners, breast cancer surgeons, physicians, you know, you name it, that we have representation. And I also just wanted to say that with screening, the only other thing that I did not mention, which is important, and it is that there are some recommendations that women at the age of 75 stop screening. And I also am not in agreement with that. And what our society says is that as long as you are willing to receive treatment and you have a life expectancy of at least 10 years, then you should proceed with your annual mammogram. You know, and I don't know if you all, I'm sure my grandmother is a 92-year-old, but she's like a good 92-year-old. Okay, so that's what I always say. And so, you know, just sort of consider the person and not just the number or age.
And so with that, how do you get around the insurance, right? Because many people will tell you, they always go, and you'll go into the office, oh, we don't cover that, right? Which I hate. And I know, Jean, that your organization has been helpful with that as well. But how do we help individuals become advocates for themselves? Rosie, I'm going to throw that to you, because I think that's really, you know, the ability to advocate for yourself or for those that you are working with is so critical, because you can just get a message of, you can't do that. Okay, I can't, right? So how would you tell us to navigate ourselves?
Yeah, I think it's a really interesting question. I think there's a lot of different layers to that question. I would say that if you're working with a medical office and they're kind of telling you we can't cover that, I think that it's really important to know, are they following that up with, this is, you know, the way we're going to work on this to try and see what we can do, or this is an alternative if we can't get what we want, instead of just shutting it down. I think that it's really important that people feel like a sense of comfort and safety minimally, like their physicians and their doctors' offices and their professionals have their back. If you don't feel that, I think that's probably something that then we have to reevaluate of, is this the right office or provider for me? In terms of insurance and insurance companies, they can be really difficult and they're changing all the time. And so I think that if you are looking for some sort of guidance, if people do want to call their insurance companies themselves to ask why they're not covering something, or to see what the process looks like to try to appeal that, that's something that they can definitely work with their nurse navigators or social workers, patient navigators, whoever's in that role, to kind of discuss to figure out different ways around it, or the correct wording to ask for exactly what they're asking for. Because I think that there are a lot of times where we don't have the language exactly that we need. And therefore, I think it's important to partner with our professionals to see what is the language that we need to ask the correct questions.
Thank you.
And Mitt, I have to just add, because insurance, it just drives me crazy. I'm sure the healthcare providers on this call, it's even harder. But the fact that people have to fight for like the care they need and the care their doctor thinks they need with an insurance company is so frustrating. So I'll just say a couple of things. One, never pay a bill until you've received it. Never pay right away till you've had it reviewed and until you've made sure everything is right. There's always mistakes. So that's something we always tell people. There's an amazing organization called Triage Cancer. And they provide so much advocacy information on many, many things, but including health insurance, as well as your rights as a cancer patient in the workplace and many things. So I can link their website, but they're an amazing resource. The other thing we see a lot of breast cancer patients getting caught up with, as I said before, there's a lot of new treatments. The FDA is moving through a lot of treatments, but the insurance companies aren't necessarily catching up. So often there's this delayed waiting period, or you have to go through a specialized pharmacy. And this is so terrifying, especially for a metastatic patient who really doesn't want to be off treatment. So we need to get that working better. But it makes me so sad that anyone dealing with any illness has to then fight their insurance companies. So we got to just take this to Washington, Mitt, right? We got to change this.
Yeah, we got to change it, right?
Bad.
And we got to get social workers hired in those insurance companies. I always say that, they need to be in the insurance company because we can make those decisions then, right? If we if we're able to. One thing that I wanted to go back to was the question as, how this affects the trans community. And you talked about hormones. So Dr. B, could you tell us, by taking more hormones, what that affects and how we have to pay attention to that?
Yeah, and the easiest way to sort of explain it is we know that for persons who are born female and exposed to estrogen, progesterone, which are hormones, just by that exposure, there is an increased risk for developing breast cancer. And in fact, the longer you have estrogen or progesterone exposure, period, the greater your risk of developing breast cancer. So an example would be when we do our risk assessment, we'll ask, at what age did you start, for females, what age did you start your period? And then what age did you go into menopause? Because we calculate that exposure, although you still are getting some exposure. And we also ask, are you taking hormone replacement therapy, which is extra estrogen for menopausal women? Because then that's extra estrogen exposure. So for all individuals, any exposure to estrogen, progesterone, increases the risk slightly. Now, I should say that is additive. So it doesn't mean that just because someone has estrogen or progesterone exposure, that they're absolutely going to get breast cancer. It just means that it is a risk factor. And so it's something to certainly consider. And I agree with Ms. Sachs in that there's just not enough data to date to make any special recommendations. But I am someone who does a lot of top surgery, tell my patients that, they still have to be thoughtful about, still have breast tissue, and you got to still do breast exams. And often the top surgery is not a complete mastectomy. And, and so you're going to have breast tissue. So I think it's, education that has to happen. And as we learn more, I think we'll be able to push the needle and provide that education that's needed.
Okay. Carissa, what other question did you come up with?
A question that actually came up a lot of the time was, is breast cancer random or are there specific causes?
Jean, I saw your mouth go open, so I'm going to come up to you.
It's a big question, and I'll say what I can. I'll let Dr. Jolley help me out. But different than what most people believe, less than, I think, 7% of breast cancer is hereditary. So I know when anyone's diagnosed, the first thing they say is like, but it's not in my family. And why did I get this? So let's remember, most cancers, at least from what we know right now, we're making lots of headway in better understanding genetics, and there will end up being a lot of other genetic mutations that will point to family. But right now, most is not. So we have very little to say, I think. When did you have your first child is something that they look at. Your weight, how heavy you are, if you have estrogen-driven cancer. But remember, some women have what's called triple negative breast cancer, and that's certainly higher in the African American population. And that kind of cancer is not driven by estrogen. I think there must be environmental factors. There must be things about the food we're eating. But I think what is so hard is, in terms of real hard scientific research, we don't have a lot to tell people about what to do for prevention. But Dr. Jolley might see it differently.
No, I think you said it exactly right. I think about it like it's a puzzle, and we are slowly putting pieces of the puzzle together. But and some of those pieces are what you've already talked about. For certain populations, there is a increased risk for triple negative breast cancer. I have colleagues who are really doing some wonderful work in looking at genetic ancestry and how link with West Africans and African Americans and Black Americans, why there's the triple negative link. And so there's some genetic, questions that certainly have to be asked for those triple negative. But there are other factors that, we have to continue to put the pieces together for, some of which you mentioned, but I always sort of lead by saying the social determinants, of health absolutely contribute. So, how has, for some individuals, racism affected socioeconomic status and areas in which, there are environmental dumps that certainly lead to chemical exposures. I mean, it's multifactorial, and that's not a black or white thing. That is, sort of reality in this country, that socioeconomic status also decreases one's access to quality care. But we're talking about risk factors, so I won't go and preach on that, right? Because I can't. But the risk factors that you mentioned are what we know, and even again the estrogen exposure. They're also modifiable, so they're modifiable and non-modifiable risk factors, and we've talked mostly of non-modifiable things that you can't control. Things that you can modify that we know are risk factors are, of course, tobacco smoking, as well as alcohol consumption. We know that there is some data to support an increase for breast cancer. We also know that BMI may contribute to one's risk of developing and recurring from breast cancer. And so we try to educate on nutrition and healthy eating habits. So those are some of the risk factors.
Yeah, we want to hear also from our audience, so we can start posting some of those questions up. But one thing that I want to say, ask you all, I was just reading an article about why so much breast cancer is always found in the left breast first. Is there an answer to that, or is there research on that?
I think it just seems like it's always on the left side, but it really is. It's both sides. I do say that, hey, I have a lot of patients from the left side, so maybe there's something to that we have not, discovered.
Okay. Yeah, I haven't heard that, but I know that when you have breast cancer on your left side, and if you have to have radiation, you have to be very careful about protecting your heart. And we do have a lot of information about that. So it's something I think doesn't get talked about enough. There's technology that helps with that, but there's also the deep inspiration breath hold to just pull the heart away. So anyway.
And then also with the lymph nodes, like, you don't have I know when I go and they put the blood pressure, I always have to say, not on my left arm. Why is that? And we can answer that question and then go to Tony Alexander's question, who's always there for us, about what ways we can support loved ones. But why can't I have the cup on my left arm if I had surgery? I know the answer, but I'm going to ask you to kind of tell our audience the answer.
Sure. So, so we do advise patients to be conscious and thoughtful about any extra pressure or increased risk of infection on the arm in which lymph nodes were removed. So lymph nodes are typically removed from the axilla, which is underneath the armpit right here. And those lymph nodes, the function of lymph nodes is to drain and clear out. And if it's not able to do that, you know, there's an increased risk of developing lymphedema. And so with the blood pressure cuff, there is the ability to sort of cut off the flow to maybe some of those lymphatics that are still existing. So we don't like to increase that. But we also say blood draws to avoid, if you can, blood draws from that arm, because that's an induction of a needle that can increase the risk of infection if you're already sort of compromised with the lymph node or lymphatic system that you have. We want to prevent that. Of course, let me just say that I tell my patients, if it's life or death, you give both arms and we keep it moving. But, you know, in a time when it's outpatient and there's time to really be thoughtful about blood draws and blood pressure checks, we say give the other arm. Okay.
Jean, I think this is a question to you to kind of help families, because I do know that some families if you don't have a good marriage, sometimes it breaks up. You know, everyone is at their own process of, oh my God, mom has breast cancer and what happens, or my spouse has breast cancer, or they just decided to have their breast removed, but you know, some men are like, oh my God, you got to have your breast. I mean, how do you help women or whoever's in that situation make the best decisions for themselves and be gone with everything else, but then help a family be supportive?
Yeah, and I'm sure Rosie will have good information too. I think that with any illness, you know, it does affect the entire family. But I think with breast cancer, because women are often playing many roles, you know, it really has a bigger impact. So we always say, don't ask what you can do, just do. You know, and that doesn't mean bring over 10 lasagnas. That might not be helpful, but it might be, hey, I'm running to the supermarket tomorrow. What can I pick up for you? And just give me your list. Or, you know, I'm going to come pick up your laundry. If they have kids, I'm heading to the same birthday party as you. I would like to pick them up, or offer to go to treatment. You know, often when you're the patient, it is really hard to ask for help. Women have trouble doing that, but also it's hard to think about. You're thinking about so many things, you know, what do I need? And you also don't really want to give up control. I think control is a really big issue. Cancer takes away, you know, a lot of control, and it makes you feel like your body betrayed you. And so a lot of women just hold on to everything they can. So I would say, think about what can you do? Can we set up a meal train? Can we do things where you still have some control, but you know you're surrounded? And I want to just also talk about people who live alone, because we often focus on patients who have families or partners. But remember, a lot of people get cancer who are alone, and making sure that their friends and extended family are reaching out to them as well. But Rosie, I'm sure you have a lot of families coming to you.
Yeah, I think I hear a lot of the same things that you're saying from the women. So I think it's important to note that a lot of people who do come in to see us, they're used to being very independent and taking care of other people. And one of my patients had said it really aptly. He said, I just have to teach myself how to receive the love that I've been giving for so many years. And I thought that was just such a beautiful way of putting it. So it is something that I do kind of reflect back to people when I meet with them directly. I would say with families, you know, it's a great idea, like Jean said, to just kind of do and still be able to give options. And I think that that's really important, to still be able to maintain giving options, or even later on after you've been doing something, if you're thinking about it and not sure, even checking to say, would this be helpful for you if I did this for you? If I just pick this up while I'm going to the store, would this be helpful? And I think that gives someone the ability to say, you know, yes or no. Sometimes people are used to being a little bit more isolated. And so it might feel really overwhelming if they have a lot of people coming to their door, especially like Jean said, if they live alone. And so I think there's just a really careful balance to strike between respecting someone's boundary and at the same time letting them know that they're still loved and not alone.
So, so Rosie, how would you help a mother and a father tell kids that that breast cancer is there? So many people try to keep it a secret, right?
Yeah.
And the kids know what's going on. Go ahead.
So it's very age specific, you know, and I think that it's really important to note that kids are very aware. So they know something's going on, even if you're, you know, trying to keep it from them. And so it kind of depends on the age group. I would say kind of blanket, it's okay to start the conversation of, you know, mom's going to the doctor, or, you know, if you have any questions, feel free to ask me, and be able to keep that conversation open. A lot of the times I think that parents feel really concerned about what it'll do to their children's grades or their day-to-day living. And so I would say, you know, yes, there might be some changes when we announce that there are changes happening, or somebody's sick, mom is sick, and things are looking different. I think it's important to note that there will be changes, and that's okay. It's good to get that conversation started with school if you have school age children, and let, you know, guidance counselors, social workers, teachers know, like, hey, this is what's going on, and letting them be aware so that they also are able to build whatever extra support layers that they can in that sense as well.
Thank you. Thank you.
Can I,
Carissa, we'll
can I
get
add one
Of course you
resource?
can. You don't have to ask. Just jump in. You're at my house.
I know, that's right.
Uh-huh.
So Living Beyond Breast Cancer does have a resource called Reading for Reassurance. I will get that link also. It was started by a woman who was diagnosed with metastatic breast cancer when her kids were all under 5. I think she had 3 kids, and she was a teacher. And she said, you know, when my kid, you know, when I have to tell someone hard news, I need a book. And so we have collected books for all ages. We send them out for free. So people just go on, put in their age range, and we will do that. And I think it is really helpful. We need more books, just so I say this, for diverse populations. We have found a few, but there's not enough. And we also need more books for teenagers. There's more for kind of younger, but that is something that I think can at least start the conversation. It's not going to solve everything, but start it.
Another role for these social workers who want to be journalists: write a book, right? And go. Carissa, let's have a question from you and then a question from the audience.
All right. So one of my questions that actually came up a lot is, what is the most effective current treatment?
As it relates to, so there are different types of breast cancer. So that's a broad question. So let me try to get a little more granular with that question. So the latest treatments, you have different types of receptors that we look at. So we talked about estrogen and progesterone, but there's also a protein called HER2. And there can be a combination of those 3 being positive or negative. And so if I just were to break it down into 3 categories, we talked about the triple negative breast cancer, which can't be treated with hormone pills. So there are chemotherapies that are sort of the latest treatment for that. And there's hormone positive breast cancer that's often treated with the hormone pills, in addition to, of course, surgery and plus or minus radiation. And then you have HER2 positive breast cancers, which are treated with targeted therapies. That's the sort of easy way of answering that. With that being said, there are targeted treatments for metastatic breast cancer. There are treatment algorithms for patients who receive neoadjuvant chemotherapy versus adjuvant chemotherapy. And so there are treatment algorithms that we follow.
So it is so complicated. So I just want to add a couple of things. First of all, I mean, Dr. Jolley's right. Like, depending on your breast cancer, you're going to have different treatment, which is why it's not very helpful to talk to your neighbor right away, because your neighbor might have had a totally different kind of breast cancer. So I think the treatments where we have a target can be more effective. The treatments can be less toxic. But for the triple negative people out there, we should remember that chemotherapy is extremely effective with early stage triple negative breast cancer, more effective, actually, I believe, than for those that are estrogen receptor positive. And if you make it 5 years out with triple negative, the chance of recurrence is really, really small. But I think this really points to why a breast cancer diagnosis is so overwhelming, because there are a lot of choices in treatment, and often the women are like, you could do this or you could do that. And remember, surgery, you know this, Dr. Jolley, used to be the really big treatment for breast cancer. And the role of surgery has really changed dramatically. So you can't really say what is the most effective treatment, right? It's not one disease. Yeah.
So maybe this is another question that we could ask, as Greg, I know, is going to put up some questions. One question that I want to ask before we get to this one, Rosie, read this question, is what is the process? So all of a sudden, I think that, the process of breast cancer, you feel a lump and you go in, and what's the next thing? I mean, how do you get to all these stages of whether it's this or whether it's that? I mean, what's the next step after finding a lump that you would do?
Right. So when you find a lump, the first step is to see your physician, and you should have imaging that is that's ordered. Now, I'll take a moment and say, listen, I love my physician colleagues. But my sister said something to me that resonated, and I thought that it was on point. She saw a physician, and she was diagnosed with something, just random, and she went and saw another physician. He said, "Well, this doctor said that I have X, Y, and Z." And she said, "Well, did he run any tests?" And she said, "Well, no, he just said I have reflux or whatever it is, right?" She said, "Well, that's an opinion. It's not a diagnosis. A diagnosis, you really have to support with fact." And I say that because I do have, especially younger patients, who come in and say that they had a mass and nothing was done. And then it ended up being something. And there are things that we can do, ultrasound, mammogram. So I just want to take a moment with that. But you'll get imaging of some sort, ultrasound, mammogram, and sometimes MRI. But mammogram and ultrasound are the first steps. And then that's followed by a biopsy. So now you have the biopsy and it comes back positive for cancer. Now, this is why it's important to leverage, areas where you do have social work support. What we have in every practice is different, is actually an access nurse that, when you're referred over, when the patient is referred over, our access nurse obtains all of the information prior to their visit. And we actually have a multidisciplinary day where patients then come in and they see our whole team. And that's not the case everywhere. And I also will say it's not great for everybody, because it can also be overwhelming. And so we sort of help choose those patients who we think would benefit from it. And they see the surgeon, the medical oncologist, and sometimes radiation, the first day, as well as the social worker, the nurse navigator, the genetic counselor, as well as the clinical trial team. So those are a lot of steps as a first step. What I tell the patients is that, when they come in, they may not, I only expect for them to really absorb about 30% of what we've said. And so we actually have a video that we give patients to watch, and we write everything down. Just like Ms. Joyner, just like your doctor wrote things down, we write it down so that they can go with their loved ones. And oh, by the way, we also agree that having someone come with you is of utmost importance, because they can help you sort of break down what was said past the visit. I think about breast cancer treatment like, we're pulling different tools out of the toolbox, and we pull every tool that we need out of that toolbox to fight and beat the breast cancer. And it really depends on the type that you have and your medical history. But the order in which we pull it out, again, depends on those factors. And so that is sort of the quick and skinny on if you were diagnosed with
Thank you. Thank you. Rosie, that question's for you.
Oh goodness, this is a really good and I know a very commonly asked question. I do want to, before I answer this question, just address what Jean had mentioned about kind of being careful when you're talking to like your neighbors or your friends. We see this really often with the cancer center that I work in. And oftentimes I just got the question yesterday in terms of, why doesn't my treatment look like my neighbor's treatment or my church member's treatment? And, I think that that's a really good question in general. I think it's really important to be able to share your experiences with other people who are going through similar things. And I think it's really important to be present for each other and share that experience and share in just the journeys that you're walking on. I would say that cancer is also very complicated. So not everybody's cancer journey is going to look the same. Your treatments won't look the same. Even if you get a similar treatment, your side effects might not look the same. And I think that's really important to note. And so it's good to talk to neighbors and friends. And also if something does come up in conversation and you're like, I'm not getting that, or this isn't happening to me, why not? It's important to bring those questions into your physicians and to your nurses and nurse navigators or nurse practitioners or whoever's on your team, because, it's a good opportunity to get further information of why is my cancer look a little different, or what does this mean for my care? Or does it have any effect on my care? So I just wanted to kind of put that out there before I go into this question about self-care. And I would say self-care is really complicated when you work in the health field, specifically in oncology. So every cancer center is different, but in my cancer center, our social workers, there's 3 of us, we meet with people from, surgery if it's appropriate, and we follow them through radiation and chemotherapy. And it won't always look like that, but for us, we have the privilege of getting to know someone from the door. And so unfortunately, that sometimes means that we're also knowing them to the end of their life. So it's a really long journey that we walk along with them, and it can be really hard and really heavy. And so it's really important to practice self-care. And some of those things might include, finding a community of other social workers that you really trust and can work with or can talk to. I have a few really good friends who I can just call if I have a really bad day, and they just can listen to what's going on and give feedback or not. And it's really also important to take time for yourself. And I think that a lot of times as social workers, we feel a lot of pressure to try and work things out. We're seeing a lot of the times the patients who do have a lot of needs, maybe they're unhoused or they're also going through substance use or mental health struggles while they're going through the treatment process. And so it's really heavy work to go through. And so sometimes we feel like we can't take a step back and just take some time for ourselves. But I think it's really important that you do that, especially if it's really heavy work, because if you're really exhausted and broken down, it impacts the way that you're able to function on your own and just for your own mental health.
Thank you. Thank you. And I know that Jean and Viv, you probably feel it's the same way. It's time to have respite. And if you don't have respite, then how are you going to take care of anybody? Carissa, you have another question? And Greg, you want to put up a question?
So a question that we got in was, how can social workers help women maintain their confidence while they're undergoing cancer treatment, like with wigs and makeup and all that kind of stuff?
So Jean might have some resources, maybe. They've changed a lot in the pandemic, which is why I might not have like the perfect resource, but there are some that are local. I know for here in Pennsylvania, they have Unite for Her, which is the Women's Wellness Day. And for some of us in different cancer centers, your cancer center might have a wig salon or someone who can fit you for a wig. I think it's important to just also address what's going on. I think that sometimes when our patients come to us with concerns, sometimes we're not prepared for, what comes out of a client or patient's mouth. And so they tell you this concern and it kind of flies by. And I think it's important to take your time and just sit with the person. So if they're telling you, I'm really concerned about how I'm going to look after, it's okay to take the extra time to get to know, like, what do you mean by that? Or how do you feel like it'll look, and help process that with them and sit with them. And I think that that's a really big part. Resources, they're all tailored to different areas, different agencies, and that's a really good part of it. And I think one of the most single important parts while we're doing that is just being there with the person to help give them that support as we're trying out different avenues and seeing what works and what doesn't work.
Yeah, I think you're right. A lot of this is going to be pretty local to your community, but there are for women that have mastectomies or reconstruction, there's an amazing lingerie company called Anaono, Anaono, actually founded by a 27-year-old woman who was diagnosed with breast cancer and was just not happy with the lingerie options as a young woman, and has created both bras and underwear, post-surgical bras, good bras for radiation, robes with pockets for drains, things like that you're not always told about when you leave the hospital, that, you'll have these drains and you need some things with pockets. So I think there's resources. There's a website called Cure Diva that curates some of that stuff. I just want to also say that, because this is another passion of mine, for women that are really concerned about hair loss, because for some women, hair is very important. There is cold capping, scalp cooling, and it works. It doesn't work perfectly with every kind of treatment, but it does work. We have a lot of resources on that. And there are two ways to do it. Some hospitals have a scalp cooling unit where you go and there is a unit, and then otherwise you get the gel caps you order them, and you need to get the dry ice and do it on your own. But there's been, in Europe, they've been doing this for over a decade. It's paid for by insurance. It's very, very standard. And of course, in America, insurance isn't covering it. It doesn't work as effectively actually for African-American women, which is something we've been pushing them to look at. But I just want to say, be proactive. If this really matters to you, see if this is an option. And you got to start before you start chemotherapy. So it can't be something you decide 2 treatments in.
Okay, we have a question here from Dr. Bullock about cultural and racial differences in cancer care can influence the various approaches to help seeking information sharing. Thus, there may be good reasons for talking with a neighbor or trusted friend. Can you speak to cultural differences? And our panel is diverse on purpose. That is something that I always try to make sure that we represent all of the groups. So I'd ask each of you to kind of answer that question, to speak to the cultural differences as it relates to breast cancer. I know for me that African Americans, as far as an African American woman, it was something, we are always supposed to be strong. So all of a sudden now when you have breast cancer, do you tell people? Do you not tell people? What did you do? And how to always have this persona that we're okay. And how do you say to somebody, I'm not okay right now? And so I do know for African Americans, that whole ability to be upfront and honest and open is very critical to care. So that, and I remember the first time I told my friends, all of a sudden it was like, wow, they were talking on the side, but they weren't talking to me. How is she doing? They would ask my husband, how is she doing? Rather than saying to me, how are you doing? Because nobody wanted to ask the wrong question, right? So could somebody speak to that? I'll speak to that for African Americans. What have you seen, Rosie, with your own ethnic group?
Yeah, I think it depends. I would say even within different ethnic and cultural groups, everybody approaches things differently. I do come across people who think that it's bad luck to talk about what's going on, and so they might not talk about it with themselves, or sometimes the family doesn't want the person to know, the actual person being treated. They don't want their family member to know what's going on or that they're sick, which of course leads to a different discussion, because we can't treat somebody without telling them what's going on, right? So it's a lot of navigating exactly, what does this mean for you and what does this look like? Especially just because, culture does influence, and also everybody individually is a little bit different. And so it's important to take the time to talk to somebody to figure out exactly where they stand on the matter and what it is that they are looking for, or what they are currently experiencing with their own family and culture.
And so we have a question here about Hispanic cultures believe it's God's plan, but again, looking at spirituality spirituality. How do you handle that, Jean, if someone comes to you and says, well, this is just God's plan?
Yeah, I remember we did a fact sheet once on myths about breast cancer, and there was one, a strong belief that if you cut open the cancer, it would spread, and also that cancer was contagious. So again, I think it's It's so important to talk to people you trust and get good facts. And when I said don't talk to your neighbor, that doesn't mean don't talk to your neighbor for support and inspiration and guidance, but don't talk to your neighbor if they are going through treatment and your treatment is different, because it can be very overwhelming. Why did you get this and I'm getting that? And doing the individualized thing. Yeah, I think it's so important to be respectful of every culture. And I think as a doctor, and I'm sure Dr. Jolley does this, you've got to meet people where they are and give them information in a way that they can understand it, they can absorb it. And wow, I have seen the power of spirit, being spiritual, believing in God, having religion so powerfully especially in the metastatic community.
Mm-hmm.
And I think whatever you need to sort of get you through this is great.
Okay. Women are living with breast cancer are more likely to get separated or divorced than men. What is that about? Oh, I didn't know that. I've been married for 46 years, so I guess I've kind of went over that, right? But anybody have any insight into that, about the pressure that it does put on families? Viv, do you want to speak to it?
Yeah, sure. I have sort of seen the process with patients, and actually have connected with some long term patients who express that it's that extra stress and anxiety. And I do think that I don't know if it's cultural or not, but just to speak to what you were saying, Mitt, that in the Black world, women are the foundation, and when there is an illness that sort of slows them down, it's this it sort of sometimes feels like they have no control, and they spiral out of control, and so they shut down, and I think it's an opportunity for us to I didn't know that particular statistic either. But it is an opportunity for us to investigate and have constant checks. And what I will always also say is that it's important. I refer my patients to a psycho-oncologist, and and it's not all the time, but maybe that's something that we need to think about. I will also say that we have conducted surveys looking at anxiety and depression during the COVID era with a breast cancer diagnosis. And we just know generally the whole population, anxiety and depression are up. And we've certainly have found that within the breast cancer community for newly diagnosed and survivors, by the way, that it's gone up even more. And so, it's an awesome opportunity for again, the social workers and to help, and for physicians to really try to identify ways of providing that support.
Wow.
And I wonder if this statistic has a little bit to do with the caregiver role, that, maybe when women are diagnosed with cancer and they find their male partner, if they have a male partner, is not such a good caregiver, is often the opportunity to make a change. Whereas women, I think, are more naturally caregivers. So men probably want to stay. So it is, I think, not that men can't be good caregivers, and I've seen a ton over the years, but it is really different when that primary person is not doing what she normally does. And
I'll also jump out and say that I have learned, when we host our symposiums, we include, of course, survivors, and we learn so much, but I've also learned to appreciate the after treatment, the survivorship, and I'm not talking necessarily 5 years. Of course, that's important, but immediately after, I'll never forget a patient saying, you did so much for me. We did the surgery and it was beautiful. My breast turned out fine. And, I did my chemotherapy, and then I woke up one day and was like, now what? And the reckoning of that, and went into a deep, and so it's there are opportunities for us to address this across the continuum.
Yeah, I agree. I mean, even I know myself, seeing my oncologist, monthly. And then all of a sudden, I remember the first time he said, you don't need to see me for 6 months. I'm like, 6 months? Oh my God, I got to do this by myself. And it is kind of scary, and even now going back all the time, you have to go back to the doctors. It brings back up, oh my God, what are they going to find this time? So there's all of that. I do know when we first started the show and we said 90 minutes, all of you looked at me like, 90 minutes? What are you going to do for 90 minutes? And you find out that the time just keeps going. I mean, we have tons and tons of questions. This is Breast Cancer Awareness Month. So I'd like each of you just to give us a closing statement, because you're the best. And that includes you too, Carissa, because you've done great work going out there, scouring up the questions of a group that now you can take back the answers, right? So why don't we just all just kind of give a closing statement? And Carissa, I'll put you on the spot because that's what we do. What is your closing statement?
To close out, I would just say for younger individuals and all people who may be able to get breast cancer, please go to the doctor. I know a lot of the time when we are young, we think like, this could never happen to me. I'm so young. But unfortunately, that isn't true.
Okay. Jean.
I think that was great, Carissa. You're right. I know way too many young women who've gotten breast cancer. I would just say, be informed, be an advocate, and surround yourself with a community that can support you.
Thank you. Rosie.
Yeah, I would definitely say to what Jean said, get as much information as possible as you can. I would say it's okay to stop your providers and ask questions to get as many answers as you want. You're the driver in your own healthcare. And so, we're there to support you and help give recommendations, but ultimately the decisions are your own.
Okay. Dr. Jolley.
Yeah, and I'll sort of add that as a physician, I care, and I know a number of my colleagues care, and sometimes, we need to know, and and asking those questions and sort of pushing and also saying, hey, I don't understand what you're saying, and again, I will empower you to seek other opinions if you didn't find that match. You're the driver, as Rosie said, you're the driver, and you've invited these clinicians and physicians and providers to be in the same car as you. And we all constantly talk and communicate and try to figure out the best treatment algorithm for you. But remember that you invited us in the car, and we can try to give recommendations, but ultimately it's your body. You decide which direction you want to go, and we will support that.
So in my closing, as president of NASW, I want to thank all of you for participating in this. This is something that hopefully social workers will use, get out into the community. But even though we have, and I hate these months, I hate the fact that we have Breast Cancer Awareness Month this month and that, because you got to learn about this and keep it in your brain all the time. Right. And when someone needs your services, or you're talking with a girlfriend, or you're talking with someone and they say, I feel a lump, to give them the factual information of helping them get to where they can get these questions answered. We know that breast cancer is treatable. If it's found early, we know that the statistics are far on your side. I'm a living testament to that. I've had 26 great years since I heard that doctor say, we're going to take care of you. I hope to have 26 more, and I'm not going to tell you how old I'll be then, but the fact of the matter is we are social workers, we are connectors, we are influencers. So let's get about the business of taking this month and making sure people have knowledge for every day. So when someone is confronted, you have the answers of where they can go for help. Thank you all for joining this Essential Chat with Mitt. And I look forward to connecting with all of you all who are on this call again physically, because each one of you are my friends, you're my colleagues, you're people that I just knew. And I'm so glad that you are now part of my village. Thank you so much.